Okay, today we're going to talk about meningitis, and my name's John Greene with the Infectious Disease Program here at USF and Moffitt Cancer Center. When we think about meningitis, we always have to ask, well, how do I tell the difference between meningitis and encephalitis? Well, here's some comments to may help you. Encephalitis, we think of abnormalities in brain function as being very common, so altered mental status, motor sensory deficits, altered behavior, personality, speech, movement disorders. On meningitis, the brain function, at least initially, appears normal. Seizures can occur in both meningitis and encephalitis. Stiff neck favors meningitis, and remember, the separation may be a little more difficult because both can coexist, meningoencephalitis. Now, when we think of meningitis bacterial, how common is it? 1.2 million cases annually worldwide, 130,000 deaths occur. It's the 10th leading cause of death due to an infectious disease. Neurologic sequelae, if you survive meningitis, is common. The duration of symptoms is about 1 day, so you don't have a whole lot of time to make the diagnosis. You can be dead within an hour to 2 weeks, so the average is 1 day. Now, the classic triad of meningitis is fever, stiff neck, mental status changes, although I just told you encephalitis is more mental status, but so can meningitis. Seizures occur 15 to 30%, and focal deficits 10 to 35%. Now, when we think about the causes, everyone initially jumps to strep pneumo. We got Neisseria meningitidis, Haemophilus influenza, which has dropped dramatically due to the vaccine. We got in the neonate group B strep and E. coli. We got Listeria if you're immunosuppressed. Don't forget community-acquired MRSA and sensitive Staph aureus is another big one. And then we have healthcare-associated meningitis, which is gram-negatives and Staph aureus. So, blood cultures with bacterial meningitis should be done, and they're positive 50 to 90% of the time. The opening pressure, the mean is 350, the normal is up to 200. The white count is usually 1,000 to 5,000. The range is less than 100 to greater than 10,000, and normal is less than 5. The neutrophils are usually 80%. The protein ranges from 100 to 500, normal less than 50. The glucose less than 40, and you can do the serum glucose ratio less than 0.4. Normal is greater than 0.6. Now, when you look at the gram stain, 60 to 90% sensitivity and 97% specificity. The CSF culture, 75% positive. Latex agglutination is no longer recommended. The PCR can detect the organism's 92 to 100% sensitivity and 100% specificity. Don't forget that if someone took some antibiotics, they may have a false negative CSF. And the lumbar puncture should be done before the CAT scan of the head with few exceptions. And then when you think of treatment, don't forget Decadron is used at the same time or right before the antibiotics. It's a medical emergency, so antibiotics need to be given immediately. The CSF will still be positive 4 to 10 hours after the antibiotics are given for pneumococcus, and meningococcus less than 1 to 4 hours. So you can still start the antibiotics, still do your LP, and still expect the organism to grow. The drugs that we typically use are ceftriaxone, vanco. If there's Listeria, ampicillin. If there's rickettsia, doxycycline. If there's herpes, acyclovir. And meropenem covers everything, including Listeria, strep pneumo, etc. Now, aseptic meningitis. You want to think of enterovirus as your number one viral cause. Don't forget herpes simplex. Okay, 85% will have genital lesions with herpes simplex 2, and molarets or recurrent meningitis can also occur. Don't forget HIV can give you a mono-like illness with an aseptic meningitis. West Nile can give you an aseptic meningitis as well as a flaccid paralysis. Varicella, EBV, and HHV6 can all give you aseptic meningitis. Mumps was one of the major causes, but now we rarely see it because of vaccination. And don't forget if there's rodent contact, lymphocytic choriomeningitis. the list keeps going on, by the way. Syphilis, Lyme disease, Rocky Mountain spotted fever, ehrlichiosis. This is a big one, a parameningeal source. So if someone has a infection in the epidural space, a cranial venous sinus, the cultures will be negative. Malignancy is another one. Drugs, don't forget drug causes of aseptic meningitis. And when we think of aseptic meningitis, the CSF white count less than 250, lymphocytes predominate. The protein is elevated but not usually above 150. The glucose usually is not low except for mumps and lymphocytic choriomeningitis. The CSF PCR for enterovirus will be positive 75% of the time, so don't forget to order that test. And notice that when we compare bacterial with viral or aseptic meningitis, the glucose should be normal with aseptic, whereas it would be low with bacteria. Of course, there's some exceptions. So this is what bacterial meningitis would look like. This is what a CT scan would look like. Here's an autopsy showing you the bacterial meningitis with the pus, dilated blood vessels, inflammation. The blue is all the neutrophils invading the meningeal surface there with dilated blood vessels. Now, what we want to do is a lumbar puncture to diagnose this. You can do it with the patient laying down, and here is the technique. You can sort of scrunch them together or over a table, and then you want to go right into that intervertebral space mentioned there, and then get your CSF, okay? And you can find the space, the L4, L5, by using your fingers on the crest of the pelvic bones. Now, when you get your CSF, here's a big point. You should be wearing a mask. And why is that? Because there was an outbreak of strep meningitis due to a guy that was doing these, an anesthesiologist, and he wasn't wearing a mask, and he's breathing on this hub, and bacteria are going right up into the hub. So if you do an LP, you need to wear a mask. There's been outbreaks with strep from the mouth blowing into the CSF. So this, of course, would be what? Gram-positive diplococci. So this is strep pneumo. What are some facts about strep pneumo? Most common cause of bacterial meningitis. Hearing loss is the most common sequelae due to labyrinthitis, 2 to 3 times greater risk with pneumococcus. Seizures occur 20% of the time. Coma, focal deficits are more common with pneumococcus. Shock, DIC, occurs in 11 to 16%. Decadron, Rocephin, Vanco, and decide if you want to give rifampin. Okay, so those are your treatment decisions. The prognosis mortality is about 8%, 50% hearing loss or cognitive dysfunction, which is quite high. We're targeting to vaccinate now. The 15 to 24-year-olds are very susceptible to pneumococcal meningitis. It gets there through nasopharyngeal colonization, then through the bloodstream, and then into the CSF. What percentage of patients have Kernig's and Brudzinski sign? Less than 5%. So it's not very common, and that's how to perform it. Now, what if it shows gram-negative diplococci? What would be your thoughts? Gram-negative diplococci with petechial purpuric rash. That would be Neisseria meningitidis. So we always tend to focus that all it ever does is cause meningitis. But you can have meningitis with a positive blood culture, meningococcemia. You can have it with a negative blood culture. You can have meningococcemia and no meningitis. So you could have a positive blood culture. So Neisseria meningitidis, meningitis, second leading cause of adult bacterial meningitis, number one for children and young adults. There's about 3,000 cases per year in the United States. The serogroups are mostly B, C, and Y in the United States. Remember, A and occasionally C is in Africa. And the W135 Hajj pilgrimage in Mecca is a unique strain. The risk factor is nasopharyngeal carriage. The vaccine has A, C, Y, and W135, and which one is missing from the vaccine is B, right, B. So here's your purpura fulminans with necrosis of the distal extremities needing amputation. And there you have it. So this is purpura fulminans, Neisseria meningitidis. Now the two spots that you need a vaccine if you travel is the belt in Africa because of yearly outbreaks during certain seasons, mainly December to June. And then if you go to Mecca during the Hajj pilgrimage, you need a vaccine because of outbreaks associated with that. Now, don't forget that when we think of recurrent Neisseria meningitidis, we think of terminal complement deficiency. And when we think of recurrent strep pneumo, we think of a motor vehicle accident causing a fractured cribriform plate. Now, for Neisseria meningitidis meningitis, what do you think the risk factors are for getting that? Number one, we just discussed that, right? Terminal complement. Two, if you have a preceding illness, a respiratory tract infection or the flu, intimate kissing with multiple partners is a risk factor. University student is a risk factor. Preterm birth, you were born preterm. If you smoke, you're at higher risk. If you attended a bar or disco, you're at higher risk. And if you do protective religious observance and vaccinations, you may be at higher risk. All right? So, chemoprophylaxis for contacts is 1 dose of Cipro or rifampin 4 doses. Remember the triad I told you was the fever, the stiff neck, right? And I forgot the third one. You remember it? Fever, stiff neck, and maybe mental status changes. It's more common with pneumococcus, but look, it's not as common with meningococcus. The rash is quite common. It ranges from petechial, palpable, purpura, and maculopapular. Muscle pain is severe occasionally, and you can confuse it with the flu, which has occurred in the emergency room. Pharyngitis can occur, which would confuse it with strep throat. Leg pain, this is important. When we think of meningococcal meningitis early on, the patient is complaining of leg pain, okay? That's a unique finding. You would never think of that, right? Leg pain. This is another interesting one. They say my hands and feet are cold, maybe because they're starting to go into that vasoconstrictive early DIC picture. So cold hands and leg pain with a flu-like illness, think about meningococcus. DIC, low protein C, shock, purpura fulminans, 15 to 25%. The treatment, if they go into purpura fulminans, by the way, is protein C concentrate. The vascular gangrene, the pictures I showed you, the necrosis, infarction of the adrenal glands, Waterhouse-Friderichsen syndrome. On autopsy, when people die of meningococcal meningitis, the heart is involved in 50% of the cases, myocarditis. Prognosis correlates with a substance called lipolignosaccharide in serum and CSF, which we don't measure, but in the research setting they found that correlated, and the mortality is 6 to 12%. Now, what do you think this bug is? A gram-negative coccobacilli. What's that? Well, that's Haemophilus influenza, right? So, the leading cause of bacterial meningitis prior to the vaccination, 85% or less than 5 years old. So we rarely see it now. So, we don't even think about it. Most infections that do occur are non-typable. By the way, they had an article recently about Haemophilus influenza in adults, and they found that because of the vaccine, the type B strain has disappeared, and the non-typable are causing some increasing infections in the adult population, COPD and things like that. How about neonatal meningitis? So group B strep colonizes the GI-GU tract of 15 to 40% of pregnant women. Vertical transmission after labor and rupture of membrane. Early onset is birth to day 6. Late onset is day 7 to 89. And late onset is after 3 months. So this can occur over a long period of time. We have in the United States universal screening for pregnant women. So here's a survivor of group B strep neonatal meningitis. It can also cause what other infection? Pneumonia, So there's a kid with pneumonia with group B strep. It's acquired during vaginal delivery, nasopharyngeal colonization, beta hemolytic, and here is the screening mechanism for pregnant women to put them on ampicillin or penicillin if they're positive for group B strep. Now, when we think of pregnant women, we think of what? Listeria monocytogenes. Who else gets it? Neonates, the elderly, the pregnant women, the immunosuppressed. It likes the CNS and placenta. Look at that, 20% mortality. It's the second most highest mortality due to a foodborne illness. Do you know what the number one highest mortality due to food is? Vibrio vulnificus. So Listeria is very high. The risk factors are steroids, treatment with TNF alpha antagonist, heme malignancies, solid malignancies, organ transplant, especially kidney transplant, diabetes, end-stage renal disease, people on dialysis, iron overload. It's one of the liver bugs, right? Liver, Listeria yersinia vibrio aeromonas. That requires exogenous iron. Collagen vascular disease are at increased risk. Other non-malignant diseases. Interesting, one study found a colonoscopy. I doubt that's a big deal, but notice what is not on the list. What's not on the list? Jumps out at you. HIV. HIV is not a risk factor because the immunodeficiency is not the right kind for Listeria. So here's your gram-positive rods. It lives in the refrigerator, in your hot dogs, your cold cuts, your soft cheeses. It's cryophilic. It grows in the cold. That's the famous Mexican soft cheese outbreak. It also likes the midbrain, so it likes to form micro abscesses in the pons medulla. That should be a clue of Listeria. It's called rhombencephalitis. Okay, rhombencephalitis. The CSF may be negative. It loves to go to the placenta. The baby is born dead, and that's called infantum granulomatous septicum with granulomas all over. So miscarriages. Here's the granulomas in the placenta, staining positive for Listeria. There it is, penetrating a cell, moving cell to cell, evading the immune system, happily coexisting and living inside a cell. And remember, it's beta hemolytic, unlike other gram-positive rods that are not. And if you do a semi-solid auger, stab it, it will migrate and give you the umbrella sign. So motility is the other thing which are not found with anthrax and diphtheria. Now, who gets Listeria? The older person and the very young. And if you do get it and you're older, notice that the vast majority also have comorbid illnesses, including cancer, kidney, liver disease, diabetes. So the comorbid illness with the elderly is important. This is the famous soft cheese outbreak from Mexican soft cheese, Los Angeles. 13 stillbirths, 8 neonatal deaths, 29 overall deaths, and 8 non-natal. So that was a high mortality. 86 cases of Listeria were identified. And then if you can read French, this shows you how you eat it. You may not even be that sick. It goes through your bloodstream. It may wind up in the placenta, goes right into the fetus, and you got granulomas everywhere, miscarriage. Now, when we think of bacteria, just to rehash, we got strep pneumo, Neisseria meningitidis, not a whole lot of H flu anymore. Don't forget Staph aureus makes up almost 10% of bacterial meningitis. And then Listeria, remember those risk populations. So when do I think of Listeria? If you're over 50 or you're younger, think of Listeria. 2 to 50, mainly Neisseria and strep pneumo are your main pathogens. Now, this guy had a large meningioma that was resected, and he develops a CSF leak because they had to go through his nose, through his sphenoid sinus, and so drip, drip, drip. How can we tell that's CSF? We can do a glucose test and look for the halo on a filter paper. And then this is a post-surgical meningitis, so we want to think of Pseudomonas, Enterobacter, and Staph aureus. So Vanco, Meropenem would work fine. And there's the Staph aureus and your golden colonies of Staph aureus. So remember, Staph aureus colonizes 25 to 30% of us. So you can see by going through your nose for surgery can easily cause a Staph aureus infection. Look at all the virulence factors that exist for Staph aureus. It goes one full page and a whole nother page. And we still haven't mentioned the Pantin, Valentine, leukocidin, PVL, which is the virulence that allows it to necrose white cells, skin fat, and when that gets into your CSF, your mortality is sky high. When it gets into your lung, your mortality is actually 5 times higher than if it's PVL negative. So you can imagine what happens when it's in your CSF. So when we think about drugs to use, because of some Rocephin resistance to strep pneumo and Staph aureus, combine it with Vanco and Rocephin, ceftriaxone. You can add ampicillin if you think it's Listeria. If you don't want to use 3 drugs, you can use meropenem, which covers strep pneumo, Neisseria, H. flu, and Listeria. So then you could do meropenem plus Vanco. And then you have to decide, the decadron goes in. Do I need herpes coverage, acyclovir? That's always, a question for you. And these are all the cocktails and combinations to think about. Remember, for Listeria, Septra and ampicillin may be your best combination. And don't forget the decadron, okay? Now, this kid has an aseptic meningitis, has a rash. So what do you think that is? You guessed it, enterovirus. So we got Echo, Coxsackie, enterovirus. The number one cause of aseptic meningitis is the enteroviruses. Remember, you get that fecal oral. So here's an outbreak associated with swimming in a crowded swimming pool where they had an outbreak of 24 cases of enterovirus with aseptic meningitis and 12 dominating. There was also a report of a mission trip to Mexico swimming in the ocean, and they got aseptic meningitis from enterovirus. What are you going to get from the pet? Hamster, gerbil, rodent. Remember that one? Lymphocytic choriomeningitis. No treatment for it. How about this one? An aseptic meningitis starts as a rash on your hands and feet, spreads all over your body, and you were bitten by a dermacenter tick. Rocky Mountain spotted fever, which is mostly endemic in the south, a little bit in the Midwest, and the hot states are mentioned there: North, South Carolina, Oklahoma, Missouri, and Arkansas. Now, if you have an aseptic meningitis 3 to 5 times over 10 years, and you always find these giant epithelioid cells, you should think of what diagnosis? Mollaret's meningitis. And what happens is the herpes that's in the sacral ganglion, instead of going antegrade, giving you genital herpes, is going retrograde, giving you aseptic meningitis. What if you have a rash on your hands and 20 years later you have encephalitis and die of slow dementia? That would be what? Neurosyphilis. Right. Now, if you're bitten by a mosquito and you have cranial nerve palsies and you have an abnormality in your spinal cord, what's the diagnosis? West Nile flaccid paralysis, right? So you can have a West Nile meningitis, aseptic meningitis. Don't forget, drugs, especially ibuprofen and other NSAIDs, can cause aseptic meningitis. Now, when we think of CSF, it normally should look clear. If it looks cloudy, something is there, right? And when we think of what we're supposed to see there, with bacteria, you might have a lot more white cells, neutrophils. With viral aseptic, you'll see not as high a white count with lymphocytes, okay? The appearance will be turbid versus opalescent, a little bit of color to it. Now, what if it's clear on the right, normal, but on the left it's a little bit discolored, and we see a bunch of those things? What are those things? Red cells. So when we see a bunch of red cells, what should you think? Interesting, we were always trained that if you see a bunch of red cells in your CSF, think of herpes encephalitis But they've actually looked at that and found that that's not true. Okay, that is not true. You should think of a subarachnoid hemorrhage or a traumatic tap. So this person has a subarachnoid hemorrhage and there's blood all over the place. And we had 2 cases presented at morning report as fever, stiff neck, confusion, aseptic meningitis. Tapped them. They had a subarachnoid hemorrhage. What were the 2 people doing? It was not an infection. What caused a subarachnoid hemorrhage in a healthy 20-year-old? They were snorting cocaine, okay? So they both were snorting cocaine. They got an aseptic meningitis. They got put on meningitis treatment, and they didn't have meningitis, but it mimics meningitis. So subarachnoid hemorrhage can mimic meningitis. What are the causes of a subarachnoid hemorrhage? An aneurysm, trauma, cocaine. How do you present? Fever, headache, stiff neck. Can mimic meningitis. You may even have mental status changes. So it's the perfect mimicker of meningitis. Here's what it would look like if you're a visual person. By the way, blood is very antigenic. You will have a terrible headache if you have a subarachnoid hemorrhage. And so my neurosurgeon friend says, give them Decadron. It'll relieve their pain. It won't make it go away any faster, but at least it gives them some relief. This would be a subarachnoid hemorrhage. And there's another picture with all the white cells going to clear the blood out. And then subarachnoid hemorrhages occur commonly less than 5, and then you get sort of sporadic in the 50 to 80-year-olds. So let's talk about other causes of meningitis. You visit Kingston, Jamaica. You eat on the beach. You eat the salad. Tasted fine, looked fine, and now you have eosinophilic meningitis. What do you have? Angiostrongylus cantonensis, the rat lung fluke, which looks like this. Here is the life cycle. The rat defecates, the larva gets in the snail crawls on the lettuce, tomato, and you eat it. There was also an outbreak in China eating poorly cooked escargot snails. So, how do you prevent this? You make sure they wash the lettuce clearly off so there's no larva on it. Okay? This was endemic in the South Pacific, and with ships traveling the ocean and rats climbing up the ropes, it's now in the Caribbean, Dominican Republic, Cuba, and I'm sure in Florida we may get some entry here and there. So this is the life cycle of that Angiostrongylus cantonensis, not to be confused with Angiostrongylus costarricensis, named after what country? Costa Rica. Okay, and then how does this one present differently? It presents as appendicitis. So Angiostrongylus costarricensis presents as appendicitis. Angiostrongylus cantonensis presents as eosinophilic meningitis. And this is the famous publication of the outbreak of eosinophilic meningitis in Jamaica, showing you that it's endemic in Cuba, Puerto Rico, Dominican Republic, etc. 23 U.S. tourists on a cruise ship visited and came back with eosinophilic meningitis. Okay, so do you have a differential for eosinophilic meningitis? What would you come up with? Let's say you got consulted and you need a differential. Well, number one on your list should automatically be Angiostrongylus cantonensis. The next one is gnathostomia. Some people around the world eat frogs, especially if you watch that show, The Wild Man Who Has to Survive. He winds up catching a frog and eating it raw, okay? You can get gnathostoma sphingorum, okay? Eosinophilic meningitis. Now, the raccoons defecate, and your kid plays in the sandbox and puts the egg in his mouth, and now he can have a visceral larva migrans with encephalitis, high mortality, or an eosinophilic meningitis. So Balis ascaris. Cysticercosis, by the way, Paragonum westermanni, the lung fluke, can rarely also do this. So can schistosomiasis, fascioliasis, and toxicariasis, which gives you visceral larva migrans. The list isn't over yet. By the way, the number one fungus cause of an eosinophilic meningitis for your boards is coccidioidomycosis, rarely crypto, rarely myiasis, viruses, idiopathic shunts, leukemia, lymphomas are big ones, drugs. Look at the drugs that have been listed as causing an eosinophilic meningitis. So your list is long, but you can narrow it down. Now, this is called the danger zone. Why is this the danger zone? You should not be pushing and popping pimples in this area. What are you going to get? This guy potentially has it. And this is the old result. You have ophthalmoplegia. 3 cranial nerves are in this structure. A cavernous sinus. So you got a septic, cavernous sinus, thrombophlebitis right there. You can see it there, okay? There it is again. So remember when you were dissecting the skull, the venous sinuses, you had to learn the venous sinuses. There's the straight sinus, the superior sagittal. You need to be aware of these sinuses because they can get into a septic thrombophlebitis. How would you diagnose it? Well, you'd have to do an MRI angiogram, and you can see the blood flow over here is limited, so there's your diagnosis. So when you think of a septic dural sinus thrombosis, the number 1 sinus is the cavernous sinus, number 2 is the lateral sinus, and number 3 is the superior sagittal, okay? Now, as I told you, what is next to the cavernous sinus? Well, you got the carotid artery right there. You got the oculomotor, the trochlear, and the ophthalmic nerve, abducens nerve, maxillary nerve. And look how close the sphenoid sinus is, very close. So those are the 2 causes, are draining from this area of your face, the danger zone, or the sphenoid sinus. So what are the causes of a septic cavernous sinus thrombosis? Infections of the face, nose, orbits, tonsils, soft palate. The danger zone, the medial third of the face, areas around the eyes and the nose, drain in the ophthalmic veins. What is the most common cause? A nasal furuncle or pimple or boil. Don't forget the sphenoid and occasionally the ethmoid sinus. And then you would wonder, why would the palate and tonsils be affected? And that's because dental infections via the pterygoid venous plexus can go up into the cavernous sinus. So that's how you can get a cavernous sinus septic thrombophlebitis. Now, epidural abscesses do not communicate with the subarachnoid space, so that can give you a, quote, aseptic meningitis picture. The culture is negative. And so when you think of the epidural space, remember, it does not communicate with the subarachnoid space. So the most common cause would be osteomyelitis of the spine, causing a epidural abscess, and you can see pushing there on the spinal cord. Okay, so osteomyelitis, pushing on the spinal cord, epidural abscess. Treatment is surgical drainage. It's a surgical emergency. And your CSF, if you were to tap, would be negative because it's not in the subarachnoid space. So what are your risk factors for an epidural abscess? So if you looked it up, what would you think? Well, the first thing is an epidural catheter. That's logical. That's your number 1 risk factor. Paraspinal injections of steroids and analgesics, diabetes, alcohol abuse, HIV, trauma, tattooing, acupuncture, a contiguous infection nearby, bacteremia, and IV drug use are all the risk factors for an epidural abscess. What do you think the bugs would most likely be? No surprise. Staph aureus dominates, with MRSA dominating of the Staph aureus. The number 2 would be gram-negatives, 3 would be strep, and then you get into the coag-negative staph with hardware instruments. Then you get really rare with anaerobes, fungi. 6% are still unknown, and TB is very common in developing countries. Now, spinal cord damage from an epidural abscess, how does it occur? Can you think about how the pathophysiology? Well, number 1, you got direct compression. So going in there, draining it, that'll cure that problem. But don't forget, you can have thrombosis, thrombophlebitis in nearby veins, and that's not going to be cured with drainage. You can interrupt the arterial blood supply, which, again, is not corrected with surgery. And then all the toxins and inflammation can cause it. So there's many ways with an epidural abscess you may have permanent neurologic damage. How do they typically manifest? This is the key. You are consulted to rule out an epidural abscess. What are you thinking? Well, back pain, often very focal and very severe. Root pain, especially shooting electrical shocks in the nerve root. And then you may get motor weakness and bladder bowel dysfunction, and then you get full-blown paralysis. And then if you touch on the area with your finger, typically you can elicit worsening pain. So that might be your clue there. So I hope that expands your horizon, not just on meningitis, but the meningitis lookalikes, especially the subarachnoid hemorrhages. And don't forget those dural sinuses in the epidural space. All of those can mimic a, quote, meningitis aseptic. So you want to think of these things when you don't really know the diagnosis. Thank you, and we'll see you next time.